she's going to talk to us about the adjuvant treatment for high-risk ER-positive breast cancer. Thank you very much, Rika.
Thank you. Thank you for the invitation. Apparently, I was the 10th one they asked to talk. And I really don't know why I said yes. It's a huge topic. But I want to point out who are the patients that we're going to talk about. So when we talk about adjuvant endocrine therapy, adjuvant therapy, we're going to focus on the high risk, the hormone receptor positive patients that are high risk. It's a complete different talk to de-escalate treatment. And to approach this topic, I decided to really look into the issues that I have. When I see a patient, how to pick the right treatment for these patients. So as you can see on the slide, the hormone receptor positive patients, they are about 70% of the patients that we see in early breast cancer. Now, in the South African situation, we've got to realize that this is not the profile that we often see. In the clinic where we work with screening, the incidence of early breast cancer is very, very high, similar to America, 80 to 90%. But in areas like the Eastern Cape, there we have about 30 to 40% of very early breast cancers, and the majority of the patients have metastatic disease. And when we do these talks, we've got to realize the resources in South Africa, which is quite divided on a racial situation. If we look at the white women population in South Africa, 75% of them have medical aids, where if we look at the black population, only 5% of patients have medical aid. So we present this like an ideal world, but we know that even in spite of the data, we have extreme challenges in the different clinics that we serve. So when we look at this population, we're going to focus on the luminal B. As we know, St. Gallen has given us some surrogates, clinical pathological surrogates of the luminal B, like a high proliferation rate, high grade, lower estrogen sensitivity, PR negativity, and you will see that about 10% of the patients that is hormone receptor positive is triple positive. Now, Etienne covered that very well, and those patients often go for new adjuvant therapy, so I'm not going to cover that specific population, but we're going to focus on the luminal B with a high risk of relapse, as you can see, and I'm going to approach this talk by looking at the chemotherapy, the endocrine therapy, and the biologicals that we have available. When we look at adjuvant therapy, this is the ASCO guidelines of the markers that we have to and may use in this population. Estrogen, progesterone receptors, obvious, not common up in Africa. The HER2 and the ISH or FISH in appropriate situations. The Ki-67, although there's a variation and we know that it is inconsistent, it is still important that when we work with pathologists that are experienced, that you can rely on that marker, especially in the postmenopausal one. The Ki-67 is less effective in predicting and prognostic situation, but in the postmenopausal patients it is very effective. Gene expression, here we talk about the mama print and the OncoDX and the big fight between the two, and then the genetic mutation. This is important that we look at the young patients, those under 45, those with the family history, the male patients, all triple negative breast cancer, even if they're over 60. And also when you have the possibility of a PARP inhibitor in the adjuvant, which we don't have in South Africa, but the data is coming. So in this talk, I'm going to focus on some of the updates that we've seen recently in the ASCO meeting. although we can't apply it, it is important that we know what is happening in this field. So this is the approach, as Etienne showed. And in terms of the systemic therapy, we have now chemotherapy, endocrine therapy, adjuvant bisphosphonates. We have also the CDK4/6 inhibitors, the PARP inhibitors. I don't think we're on the right presentation, but anyhow, and the different endocrine therapies. Now, not a lot has happened with endocrine therapy. It's good old tamoxifen, and 20 years ago, the aromatase inhibitor, and when we look at the high-risk patients, the application of ovarian ablation is important. Now, let's look at the guidelines. I can't forward. Okay, you will. Okay, so we have two major guidelines. We have the ASCO guidelines and the ESMO. And yes, there are others, the EMO, the NCCN guidelines, and all of that. And what we find with this particular high-risk group, we find that are we going to get there?
Yes, we'll get there.
Okay, so in a situation where we have only the clinical pathological factors to identify high-risk patients, we look at next one. Yeah, that one, previous one. Yeah. We look at the clinical pathological factors. And here you can see a study that was published it's a real-world study published in 2022. And what they used as a high-risk group was the patients with more than 4 nodes positive. And those with a 1 to 3 node positive, we know it's a more intermediate group. They looked at extra risk factors like the grade 3 on the left-hand side, a tumor size, or high Ki-67. And what they found is this particular group, it's about 1 out of 10 of the patients that we treat. And they have a significant difference in their relapse rate and also the mortality rate. So there's, in the high risk versus the low risk, there's about a 3 times increase in the risk of relapse and subsequent death in this patients. So this is a very effective clinical pathological way of looking at that. You will see that age is not mentioned here. And then when we go to the guidelines, here we look at the ASCO guidelines, and I'm going to ignore the HER-positive patients. There it is, the HER-positive patients and the ER-negative patients. You will see if you go down with the ER-positive group, they divide on the ASCO guidelines the patients between premenopausal and postmenopausal. And it's confusing because we know it's a risk factor, but how important is it? And you will see as you go down in the node-negative group, they use the OncoDX. There's no reference to the MammaPrint. And if you go into the postmenopausal group, there you have the markers that you may use to guide you in terms of chemotherapy or not. And they prefer the MammaPrint in the node-positive patients, postmenopausal and postmenopausal negative, but in the premenopausal patients, not. Now, a lot of things happened subsequently. With the last 2 years, we looked at that whole issue of age. The ESMO guidelines that you see here at the bottom doesn't mention age at all. So you can pick which guideline you use. Here they say if you have an ER-positive, HER2-negative patient and you want to know whether the patients need chemotherapy, whether pre or postmenopausal, you can use the mama print or you can use the OncoDX. And this is practically what we practice. In Cape Town, we have in the northern suburbs the mama print dominating, and in the southern suburbs we have the OncoDX dominating. To put it in simple ways, I want to clarify this issue. This was the ASCO update by Dr. Soprano, and they looked at 11 years follow-up. You can see more than 10,000 patients, and the bottom line is that in this specific patient group, which is node negative, the majority of the patients can be chemotherapy spared. And the score for the postmenopausal patients for chemotherapy benefit is above 25, 26 and more. But if you are premenopausal, the score drops to 21. And this is how we use the OncoDX. Now, in the criticism against the mama print was with the publishing of the MINDAC trial. In this particular setup, they looked at patients with clinically clinically high risk, and the mama print came out low risk. And the whole issue was in the postmenopausal patient, there wasn't a difference in terms of receiving chemotherapy or not. But in the premenopausal patients, there was a 5% difference. And this was after a matured follow-up of 9 years. And again, the issue that we discussed with the mama print discussion earlier this morning, in the premenopausal patients, it is not a deficiency in the mama print model. This analysis was underpowered, and the MINDAC cannot be used to say that the mama print doesn't work in this particular group. The real reason why there was a 5% difference is, again, because the patients that received chemotherapy had a better ovarian suppression. And the analysis can only be put to bed once we do prospective studies, where we look at the outcome of the ovarian suppression of the chemotherapy or not. And when we use endocrine therapy in the young patients, especially the high risk, in that particular group, that we make sure that it is a proper endocrine and a full endocrine suppression. So we still can use the mama print in this particular group. This was a publication in 2022 by Martine Picard, putting a lot of confidence in using the mama print in this particular group. The other benefits of the mama print is the blueprint. But here on the left-hand side, I just want to point out to you all the other information that we get. First of all, the ultra-low risk, where we can cut down on endocrine therapy in the postmenopausal patients, but also in the high risk, dividing the high risk in high 1 in high 2 with certain particular clinical indications. What we, for instance, see is that the CDK4/6 inhibitors doesn't work that well in the high 2 group. And on the left-hand side, you see the blueprint. And here, Etienne again pointed out that some HER2 types are low risk and others are high risk, and we are able to identify where the targeted therapy is completely, I want to say, useless, and a cost of and a loss of financial benefits for those patients. But the more important group is this basal type. These patients have ER positive tumors, but their actually intrinsic type is triple negative, like a triple negative basal-like, and they behave just like that. What is interesting about this group is about 10 to 15% of our populations, and you're going to miss it if you don't do the blueprint. These tumors have a very, very poor outcome. You can't use the estrogen receptor. Just look at this graph on the left-hand side. Some of those tumors have almost like 100% estrogen receptor positivity. And the progesterone can be up to 50%. So how do we identify them? I get suspicious when I have a ER-positive tumor with extremely high Ki-67. And the other situation is when you do neoadjuvant chemotherapy and this thing is melting away. Be careful. Don't be happy. Check. Because you're probably dealing with a basal-like ER-positive patient. So it's important that we differentiate between these two genomic markers, the OncoDX and the MammaPrint. I really prefer the MammaPrint due to all the extra benefit that we get and that we incorporate in the treatment and better outcome for our patients. So let's talk about this chemotherapy. You know this, the NCCN guideline shows all the preferred. And in the high-risk patients, we find that most of the guidelines recommend a dose dense versus a standard protocol. And what we think is that the dose dense is more toxic. But apparently it is not. In terms of quality of life, the patients have a slightly lower score, but due to the growth factors, they actually stay in the protocol. I find that age is a problem. Some patients with comorbidities just don't get through the treatment. So I keep it for the younger patients with a high-risk breast cancer. And this chemotherapy issue, I'm going to divide it in a few questions. The one is, do we need anthracyclines? And yes, you can see that the anthracyclines and the taxanes in treatment does make a difference. So for high-risk patients, this is still the standard of care. Overall survival, not so much, but definitely improvement in the disease-free survival. So the second question is which taxane, and this very old data, the E1199, when you use docetaxel, you go for 3 weekly, and if you go for paclitaxel, you go for weekly after your IC times 4. Now, the third question is, should we use the anthracyclines and the taxanes in combination of sequential? And here you can see in a meta-analysis that the benefit of sequential therapy, it's not showing it. I'm apologizing, but the whole issue here was in the patients with high-risk breast cancer. There are several slides on each other here, and that's why you don't see the final one, that showed that if you have a high-risk breast cancer, it is better to use the sequential than the combination. The number 8 versus 6, the total dose of treatment and staying in your protocol is the most important part. So I prefer sequential, starting with the anthracycline. There was even a slight difference between the epirubicin and the doxorubicin. Doxorubicin worked slightly better than epirubicin, and they said it's because of the dose. Very few people actually give epirubicin at 100 per square if they go for dose dense. So it's important that when you pick a protocol, get comfortable with it and do it. Don't float between the different things. So the dose dense. Here you can see the 2 weekly versus the 3 weekly chemotherapy. You can see on the left-hand side the recurrence rate, and on the right-hand side the mortality rate at 10 years. So there is a benefit, and patients that can tolerate that, I think this is where we should go. If we think at dose dense, there are different regimens, but most of the guidelines refer to AC times 4, 2 weekly, followed by paclitaxel. Now, the paclitaxel can be given in two ways. It can be given every 2 weeks, or it can be given as a weekly fashion for 12. We have no data to say that the paclitaxel 2 weekly versus weekly is worse or not. But what we do know is if you do the 2 weekly paclitaxel, the toxicity in terms of neuropathy, fatigue, and neutropenia is definitely worse than the weekly. So I often look at my patients, how they tolerate the AC, and then I will decide whether I go for 2 weekly pack or a weekly pack, depending on the history of their tolerance in the previous time. Okay, so that is my questions and answers about the adjuvant chemotherapy consisting of anthracyclines and taxanes. The next issue is how can we improve the outcome of the patients in terms of the adjuvant endocrine therapy. So the first issue is tamoxifen versus aromatase inhibitors, adding ovarian suppression for the high-risk younger patients. We can extend the duration of the endocrine therapy. We also can add bisphosphonates for these patients, and then the new data regarding the adjuvant CDK4/6 in a certain subset of patients and the PARP inhibitors in a certain subset of patients. So the issue of about tamoxifen versus aromatase inhibitor, this is a meta-analysis, 31,000 patients that was followed, as you can see, for a meantime of 10 years. And clearly, by using an aromatase inhibitor, you improve the disease-free survival by about 30%, and you decrease mortality with 15%. So that is a no-brainer. You use an aromatase inhibitor whenever you can. If we look at the premenopausal patient, how important is it to suppress the ovaries? This is a meta-analysis of only ovarian ablation. Now, you can see all these factors are significant, but age is really a very, very important factor, especially those under the age of 45, where you can see there's a huge benefit, 10% gain. And the last column, you can see the gain at 15 years. Then in nodal status, not so much, positive and negative, not much of a difference. But here at the tamoxifen use, you can see by adding tamoxifen, using the combo versus a single hand in the endocrine therapy, you get a huge difference, 17% versus 4.5. And then also the type of ablation had a huge impact. Ovarectomy versus LHRH antagonist. There's a percentage of patients that actually escape that, and you have to keep that in mind and check if you suspect that the patient is not getting suppression. So in high-risk patients, ovarian ablation is huge in terms of the benefit that they do. Whether we have to add tamoxifen versus aromatase inhibitor in these young patients, that wasn't so clear. We know tamoxifen on its own is a benefit. We know that ovarian suppression. This study, the SOFT study, was a randomization of 3,000 patients. And what I really like about it is they randomized the patients to tamoxifen only, and then the combination arms, the one with tamoxifen and the one with exemestane, and they've given the suppression for 5 years. This makes sense to me in the young patients with high-risk breast cancer. And the bottom line of it is here. First of all, you can see the patients that are disease-free, and this was an ASCO update this year. At 12 years, you can see the disease-free survival. At the top is tamoxifen, 71, then ovarian suppression with tamoxifen and a slight improvement of tamoxifen with an aromatase inhibitor. And on the other side of the screen, you see the overall survival. Now, we know that this looks good, but the cost is the side effects. So, for me, it is important that when you take a patient for chemotherapy, that you make sure where they are in terms of the endocrine situation. Then I use a stepwise approach. I start with ovarian suppression. I give them a month or two and see how they cope with it. And then I introduce, depending what you prefer, according to the risk, an aromatase inhibitor or tamoxifen. If they really can't tolerate an aromatase inhibitor, I take them off, give them 2 months' time. Remember, we're going to do this for 10 years. Then add the tamoxifen and see how they tolerate. And if they really don't tolerate that, you revert back to tamoxifen only. But you can see from the top to the bottom, there's quite a big difference in survival. But by using it stepwise, you get the patient's buy-in. And this is the only way, because the drop-off is about 10% a year. So at 5 years, only 50% of the patients are actually doing the endocrine therapy. And you've got to really support them in terms of quality of life. You know, low libido, problems with sexuality, fatigue, obesity, the other issues of bone density, increased cholesterol. There's a lot of issues that we have here. And to see these patients and really focus on the quality of life is important to keep them on their treatment. Now, the other way to improve the outcome is to increase the time of endocrine therapy. The standard of time is 5 years, but we can see here the relapse rate for the high-risk breast cancer endocrine positive patients is about 4% a year. 4% for 10 years is 40%. So the younger the patients, the higher the risk overall. And that's why in the younger patients, we try to extend. How can we extend? The Atlas and the Atom looked at 10 years tamoxifen versus 5 years. What is important here is at 10 years, there wasn't much of a benefit, but stopping at 10 years, the benefit, the carry-over effect, carry on for 15, 20 years afterwards. So that is an option. The MI17 Paul Gosh looked at postmenopausal patients. They had 5 years of tamoxifen and they added aromatase inhibitor. We all know this data. There was a huge improvement, 50% reduction in relapse after 2.5 years, which is in real benefit only 2 or 3%. And we can see here the patients that benefit was those with node positive disease and the younger patients. But in the real world, we don't start with patients on tamoxifen anymore, especially in the high-risk group. We start with aromatase inhibitors. So the question is, what now? If they had 5 years of aromatase inhibitor, what is the benefit of extending it in the postmenopausal group? Now, in this update that was in ASCO, they saw that the benefit, and it's a huge study, you can see on the left-hand side, 10,000 patients, node 1 to 3, 7,000 patients. In this update, they saw that adding adding an aromatase inhibitor after 5 years of aromatase inhibitor benefit, no clear benefit, a node negative, 1 to 3 node positive, and the higher risk group. So this is where you should apply it. And you may switch from one class to another class in that. So there is benefit for a subset of patients, high-risk patients, by extending the aromatase inhibitor beyond 5 years. If you don't know, this is a magic tool. This is a CTS5 calculator that was created or published by the UK group, and you can see they use tumor size. The patients are now 5 years disease-free, and you want to know who will benefit for extending it. So you use tumor size, grade, the age, the number of nodes, and here at the bottom you get a high risk. They actually tell you what is high, what is intermediate, and what is low, and that can be used. So it's a very nice tool to use to finalize the duration. Adjuvant bisphosphonates. I think the bottom line here is there is benefit only for the postmenopausal patients. It is a small benefit. That comes with toxicity. The jaw necrosis, the kidney problems, the symptomatic problems. So you've got to do your calcium levels, your kidney functions in these patients. You have to supplement them with calcium and vitamin D. But it should be discussed with all patients, postmenopausal patients. You can also use this tool, the NHS Predict tool, to give you the percentage benefit that the adjuvant bisphosphonate will do. But it's normally 1 to 2%. It is not more than that. There are also now enough data to say that we can use oral chlorinaate, the ibondronate, or zoledronic acid. And ASCO guidelines gave us 2 regimens in terms of sequencing. I use the 6 monthly for 3 years. You should start early with this if you're going to use that. And at this stage, denosumab is not part of the ASCO guidelines. Not enough data at this stage in 3 huge randomized trials that couldn't show the same benefit as the bisphosphonates. Now, the big story this year is the adjuvant CDK4/6 inhibitors. I think what is important here is that this trial, the Monarch-E, look at high risk. This is a particular subset of patients that benefit from adding abemaciclib to the existing adjuvant therapy. Now, they had 2 cohorts. The first cohort is the clear clinical pathological, more than 4 nodes positive. And for that group with a little lower risk, 1 to 3 nodes, they must have grade 3 or tumor size more than 5 centimeters. The stuff that we, and then they will randomize to abemaciclib in the dose that we use in metastatic breast cancer as well. And they do that for 2 years and follow them up. The rest of the endocrine therapy carries on for the high-risk group. That may be 5 or 10 years according to the risk. Now, 2 things come to mind here. Or let me just quickly go. Cohort 2. That group at a much lower risk, and they only started a year later recruiting that group. So we don't have data about it, and I'm going to ignore that. But they looked at the invasive disease-free survival. What is important here is we're going to add another molecule with side effects on high-risk patients that had chemotherapy, dual endocrine therapy, and another molecule with side effects with the impact on quality of life. You will see with Natli, the one that I discussed just quickly after this, it's slightly different. And they added for 3 years. But I think cost-wise and quality of life, 2 years makes sense to me with the benefit that we see in this particular group. Here you can see the updated data after 4 years. The difference in invasive disease-free was nearly 7%. This is important. But first of all, pick the right patient. You know, the benefit in intermediate risk is going to be lower, and there's going to be no benefit in the low risk group. And it's costly. If we look at the tolerance, in general, they published it, and it's very positive. You know, almost like say, okay, is it that easy? But apparently it is that easy. Most of the side effects holding treatment grade 3 holding treatment, decrease the dose, happened in the first 2 to 5-6 months. And then everything settled. The patients reported a very good quality of life with only minor symptoms that they handle with the anti-diarrhea medication. I was surprised, but it actually worked out very well. And I think the confidence of the oncologists and, discussing the molecule and the management and of the side effects of this drug is very important to keep the patients on treatment. You will see due to diarrhea, not really. The main reason why patients, only 5% stop their treatment due to diarrhea. There was other issues. And here you can see, as we get to manage the side effects better, the patients do very well. There was, at ASCO this year, analysis looking at older patients versus younger patients. And here they reported that the side effects are definitely more in the older patients, and they often had more dose reductions. So keep that in mind. Those patients need closer contact and better follow-up if you want to continue for 2 years. NATALEE was also discussed at ASCO. Now, this is a different group, and here on your left-hand side you can see that the patients that they included were different. First of all, they included patients with an earlier stage. They included patients with a lower risk. And then when they randomized, the dose was 400, not 600, as we know, so it was reduced, and the treatment time is 3 years. They reported, here's the difference that I wanted to show out, they had a third of the patients were node negative. In Monarch E, we had only node positive patients. So this is a molecule for a subset of patients where you have high-risk node negative patients. And you will see the 20% had 2A, where we started with a Monarch only at 2B, 3A and 3B patients. This was what they reported. You can see it's 36 months, a 3% benefit in event-free, but at this stage, only 20% of the patients completed their treatment. So it's really very early days here. We'll see how it goes, but that was a focus point. Another focus point at ASCO, and this is the last component of improving the outcome of the hormone receptor positive patients, was the Olympia. Now, again, it's high-risk patients, and they were tested for BRCA1 and 2, germline mutation. This is not for it's only germline BRCA1 and 2. And they, I'm going to focus here at the bottom, the hormone receptor positive patients. They're high risk, they had previous chemotherapy and not a complete response. The other option would be they had surgery and adjuvant therapy at starting with more than 4 nodes, 4 and more than that. There is the funny CPS EG score that they used. They basically look at the stage before chemotherapy, and then they look at the stage after chemotherapy. And that, if the score is more than 3, the patients were high risk. And again, here we see in this subset a huge benefit. Look at the difference at 36 months, 8.8 in the primary endpoint, which was invasive disease-free survival, nearly 10%. This is huge. We don't have it available. Even in this early stage, we could see a survival benefit of about 3.4% at that stage. So toxicity, it is there. Majority is nausea, fatigue, and anemia. Can you now imagine the young patients go through chemo, combination, CDK4/6? You use this after the CDK4/6 inhibitor in combination with your combination endocrine therapy. Hectic. So the price is huge. When we treat these patients, it is you go for the long game. And everything has got price, as Etienne said. And I think this makes it difficult. It is really important to realize, yes, it is FDA approved. It is not for everybody. The cost is about 90,000 a month. I don't know if we ever will get there. Even in the metastatic setting, we don't get it for the hormone receptor positive patients, only for the triple negative patients. And that is my update. There's a backfill. I hope I've covered most of your questions. And yeah, that's me. Thank you.
Thank you very much, Rika. It was almost like a clash of the titans. Who's going to give the best talk between Rika and Etienne? I was actually thinking of having a debate between the northern suburbs and the southern suburbs, but I couldn't get speakers from the southern suburbs. So that idea went out the road again. But maybe for the next talk, we'll have a little bit of a debate and then we'll vote and we'll see who's the best, like a boxing match. So is there any questions? Justice has got some.
I would be here if I were not to make a provocative statement. Now, Rika, you pointed out online. Oh, sorry. I greet all the online people, especially those in the Karamadulas. Okay, now, Rika, here comes the provocative statement. We know that endocrine therapy's toxicity, and I'm talking about aromatase inhibitors and tamoxifen, is highest in patients who actually would benefit the most, because there's a tie between side effects and quality or quantity of response in endocrine therapy. But you always say to us, we surgeons are the ones that are living in the past. But I'm telling you, we have brought down the toxicity of surgical treatment by going from radical mastectomies to modified radical mastectomies to tumor excisions to oncoplastics. Where is the contribution of the oncologists? Because it has been shown, for example, for tamoxifen that 5 milligrams is effective as to what concerns cancer-related parameters as is 20 milligrams. However, the side effects are much less. Why haven't we seen that in clinical trials of a required magnitude? Wait a second, I've got more. No. Yes. And, okay, point taken. And number two, we know that the aromatase inhibitors, they're all effective in the same way. If you look at clinical data, the reduction of mortality is always the same. However, and this is what I don't understand, anastrozole, it's much less effective in the suppression of estrogen levels in the blood than is letrozole, than is exemestane. So that indicates to me that you, or the oncologists, are giving it at maximum tolerated dosage and not at minimum effective dosage. So if we were to find out what is the minimum effective dosage, we would actually ensure that an awful lot more patients would stay on treatment due to the reduction of side effects, and we would have a much better and happier patient clientele.
In terms of tamoxifen, the 5 milligram dose versus 20 milligram was not in infiltrative invasive breast cancer. It was only in DCIS and prevention of progression, and that Italian study. So it's interesting. It's not been tested in other studies, but that's the one factor. So we don't know about the invasive prevention. Tamoxifen versus nothing cut the relapse by 50% and mortality by about 25%. So it's an effective drug. But we know it differs in metabolism between different patients and drug interference. So that makes it more difficult to use. But it's not just something that I would do for each and every patient. Unfortunately, We don't have endoxifen measurement in South Africa. That would be fantastic. So then we can test the active component of tamoxifen in each and every body. And that will give you a better idea. In terms of the aromatase inhibitors, yes, you're right, but you're not 100% right. We see that in the Kaiser, in a study in the Kaiser unit in Canada, that the body mass index was a huge problem. If you use an aromatase inhibitor and the patient's body mass index is above 30, even worse, above 35, that the benefit of the aromatase inhibitors dropped to 10%. So tamoxifen works better in the obese patient, but we've got to realize each and every body is not the same, and you've got to juggle the drugs available with the patient in front of you.
Idea was north versus south, not north versus north.
But like in a good marriage, we have our conflicts. That is indeed true. But if you look at what actually happens with the aromatase production, there's an awful lot of aromatase coming out of fatty tissue.
Yeah, that's
and
why.
My question was, and that was the original question actually, are we using the right dosage? Have we engaged enough in those finding studies? We haven't, in my opinion.
Yeah, I'm sure that anastrozole was tested in 2 milligrams versus 1 milligram and 0.5 milligram. That has been done, and the 1 milligram was the optimal, and it was more effective than the 0.5 milligrams in that study. So I'm comfortable to use the drugs in the way they 3 different structures. They have different side effects in different patients, and I switch from one to the other until I find the one that the patient is okay with.
Justice.
I would like to hear your comments on the baby break in endocrine therapy for premenopausal patients.
Yeah, what is that study? The POSH study that looked at the safety of have a pregnancy after the diagnosis of breast cancer, and they looked at endocrine negative and endocrine positive patients, and in both incidences they found that the pregnancy itself didn't affect the outcome. The recommendation was to give 2 years of endocrine therapy. Those patients then get 2 years to get pregnant, and after that they have to start with the endocrine therapy and complete 10 years of endocrine therapy. So I recommend that according to the guidelines.
I think that trial actually showed the pregnant patient did better.
Did better, yeah, just shows you.
It's a lot of selection bias. I mean, you're not going to ask someone that's high risk to stop their treatment.
Yeah, I think the inclusion of the patients in that trial is probably playing a role in getting that. Obvious, if we deal with the patients with 10 nodes positive, we're not going to push that patient, and we're going to put our foot down and say, you probably have microscopic metastatic disease at this point in time.